born with heart disease. The moderator, I'm called Dr. Tenywa Emmanuel. I'm a consultant pediatrician and the cardiologist working at Jinja Regional Referral Hospital. And I want to take this singular honor to announce to you our presenter today, Dr. Muhoozi Rwakaryebe Mbagga is a consultant cardiovascular-thoracic surgeon at the Department of Cardiovascular and Thoracic Surgery at Uganda Heart Institute. Dr. Muhoozi, you're most welcome. So,
thank you very much,
I want
Dr.
to go through
Tenywa.
the agenda. We shall have an opening prayer from a volunteer. Then I will give some few remarks, and then I will introduce the presenter. So, may I ask any volunteer to give us an opening prayer, and we continue with our program. Any volunteer to pray for us?
Lord, we thank you for this. We thank you for the gift of life. We thank you for this webinar, and we surrender it into your hands. We ask you to come and be with us as we discuss. May you, Lord, open our minds so that we may receive the new knowledge that is going to be given to us, and may it be used for the benefit and the glory of your name. In Jesus' name we have prayed.
Amen. Thank you so much for that wonderful prayer. So if I'm to re-echo, our presenter for today is Dr. Muhoozi Rwakaryebe Mbagga. He's a consultant cardiovascular-thoracic surgeon, Department of Cardiovascular and Thoracic Surgery at Uganda Heart Institute. So let me just give some opening remarks. This presentation is in partnership with the Busoga Health Forum, Jinja Regional Referral Hospital, and the Uganda Heart Institute. I want to give a preamble about the burden of congenital heart disease in Uganda. As we all know, 1.6 million children are born in Uganda every year. But just imagine, of the 1.6 million children who are born in Uganda every year, 1% of the 1.6 million, that is 16,000 children, are born with congenital heart disease. Now, most importantly, of the 16 children who are born with the congenital heart disease, 50% of them, those are 8,000 children, they need an intervention. Now, what is the burden in Busoga? Approximately, in a year, 200,000 babies are born in the Busoga sub-region. 200,000 babies are born per year. Now, if we follow the 1%, 2,000 children are born with the congenital heart disease every year. And 50%, that is 1,000 children, need intervention. So you can all see, this is a very big problem in Busoga, in Uganda at large. So this is very timely, it's very important topic for discussion today. So the other important thing, right now as I talk, we are having a cardiac surgical camp at Jinja Regional Referral Hospital in partnership with the Uganda Heart Institute and the Busoga Health Forum and the Busoga Kingdom. And it is running from 17th to 21st of this month at Jinja Regional Referral Hospital. And so far, 8 of our children have been operated successfully. So this is good news to Busoga sub-region and the Uganda at large. So without wasting a lot of time, let me invite Dr. Muhoozi to take us through today's topic of pediatric and congenital heart surgery in Uganda, changing lives of Ugandan children born with heart disease. Dr. Muhoozi, you are most welcome.
Thank you very much, Dr. Tenywa. I'm waiting for the gentleman of Busoga Health Forum to give me access to share my screen.
Doctor, you have access because you're a co-host. Just click on share, then to be able to show up. Yes, Dr.
I'm
Ifo.
doubting that's
Sorry?
doubting that's the case because I've logged in with the link which was for signing in as an attendant,
Yes, then I made you a co-host.
and it's not giving.
So if your new screen, there is share your screen. When you click it, be able to show up the screen you want to share. You have the rights as a co-host.
Then
Just click on share screen and then share.
All right, perfect. You should be getting my screen now. Confirm on that.
Yet.
Are you getting my screen?
No, click on the slide that you want to share. There is, when you click on share, then you click on what you want to share. There are things there. Then you click share, which is down on yours. Yes, perfect. We can now see.
Okay, perfect. We are there.
yes.
Now, without wasting a lot of time, Dr. Tenywa, thank you very much for the introductions. We shall be discussing today pediatric and congenital heart surgery in Uganda, changing lives of children born with heart disease. Briefly, the country profile of Uganda, the population as per 2023. I don't know if anyone is familiar with the results of the recently concluded census, but I'm still going with the ones of 2023, 48.5 million approximation, with a gross national income per capita of 2,650, life expectancy for males 60 and females 65. Total expenditure on health per capita as per 2022 of $36.9 and total expenditure on health as a fraction or percentage of our GDP of 3.83. We should note that almost 40% of our national budget is donor funded or was donor funded before a bill in Parliament was passed. And we don't have a national health insurance scheme. The profile of the leading center or the one center alone charged with the care or the management of cardiovascular disease, that's the Uganda Heart Institute, which was established as a national referral for cardiac care in 1988. With heart surgery programs for open heart surgery starting in 2007. It has got a ward capacity of 70 beds, putting that into perspective, 70 beds for the 48.5 million population, and an ICU capacity of 7 surgical beds and 4 medical ICU beds, 1 operating theater, 1 diagnostic intervention or catheterization, and currently with a plan of seeing how regional centers can be revived to help on reducing on the disease burden. As per this year, only 2 regional referral hospitals or 2 regions have had a collaboration where heart surgeries have been performed. That's Mbagga and Jinja for this period where we are here. To jump in, the burden of congenital heart diseases in children is a serious or a major cause of serious morbidity and mortality in children of all ages. It is estimated that about 15 million children globally are crippled by heart disease, and this is more especially in low-income countries. In Uganda, to translate that into perspective, 1.6 million babies are born annually, and of these 1.6, 1% present a congenital heart disease, and half of those would require an intervention or surgical or medical management. So 1% of 1.6 million, that we are looking at around 1,600 children who are born with heart disease. So although the incidence of congenital heart disease globally or worldwide is similar as in presentation of cases, this burden is more heavily felt in our type of countries, low-income countries, due to a number of factors. One of those is that low-income countries are characterized of high fertility rates, as common in sub-Saharan African countries, South American countries, and Southeastern Asian countries. And this tends to be more of a burden to a single wage earner in a family of, let's say, 8 children who might be born with or having a member who presents a congenital heart disease. Now, health expenditure is a large fraction of a GDP of high-income countries. But when you look at our health expenditure, it is only a fraction of about 3.83 of our GDP, which is totally low. And we have already seen that almost 40% of our health budgetary expenditure is donor funded. When you look at this map here, it gives you a perspective of the total annual birth of children with congenital heart disease globally. When you look at Africa, you will see 335,000. When you go to North America, 71,000, then South America, 65, Asia, 725,000. That they are high population countries. When you single out China and India, they account for that massive number. But all these other countries have got developed systems which work to reduce the disease burden. But when you look at our continent, it's our continent that is characterized of inadequacies in human resource, inadequacies in medical supplies, inadequacies in services, generally for the patient who would be depending on healthcare as a public form of service. I mentioned that the disease burden of congenital heart disease in our type of countries is more increased or attenuated by the fact that our countries are characterized of high fertility rates. When you look at sub-Saharan Africa, let's say where we are, Uganda in purple, you'll see that each family is estimated to have 7 to 8 children. Now, when you look at Somalia, then Niger, Mali, the same range. Then our neighbors, Kenya, 3, then the Congo and Zambia down 5 to 6. But then when you look at European countries, you'll find 2 to 3 children, North America or Australia, even 1. So you find that in each family, if you have got 7 or 8 children, the incidence of congenital heart disease will be greater than the others. And this is worse in a country where there are no systems that are well developed to cater for these patients. And then the income or the systems that would be to respond to the need of healthcare are not well developed as the others. The history of heart surgery in Uganda, surprising cardiac surgery in Uganda was established in the 60s and early 70s with the technologies which were in development at that time. As the other world was developing heart surgeries here in Uganda, there were works which were being done. And they would have developed further if it wasn't of the political turmoil and economic collapse that was characteristic of our country from the 70s to the 80s, expulsion of Asians that led to the economic collapse and then the political turmoil that ensued. From the 80s to 90s, there was a return of professionals, some of those who had emigrated to go and practice in safer environments. And then surgery started with the championship of key individuals who looked into the future and saw what would be the needs of this country. And notable among them was Professor Francis Omaswa, and then the other members who were identified and trained that are now the pillars of cardiovascular healthcare in this country. Now, the establishment of UHI now comes at a later stage, as we had seen in 1988, which comes with the recruitment, enticing, and training of professionals. Then surgery started to evolve from closed heart surgeries to more open heart surgeries with collaborations. And this laid out a cornerstone for the future development of cardiovascular healthcare in this country. Notably in 2016, out of the recognition of the works which were being done, there was an act of parliament which established the Uganda Heart Institute as an autonomous body charged in the cardiovascular management of patients in Uganda, development of strategies through research and support supervision, and laying a framework of which to build more cardiovascular services in this country. And this led to growth of partnerships and scaling up of services. This came with a number of challenges, and those challenges notably insufficient funding from the central government, and this is characteristic of all public health institutions, where you find that the disease burden does not correspond with what is put in to support patient care or to support strategies for clinical management of patients. And then still, with the teams which were available at the start of the institute, they were not so much that would meet the disease burden. Therefore, there was a lack of skilled human resource who are meeting a tremendous disease burden that was to be handled by the few that were, and by a single center which is located in the capital and had to reach out to the population who are living in the countryside. And then the limited operational space, lack of equipment, sundries, and supplies, in which you find that as the practitioner in a low-income country, which does not manufacture a number of these sundries, you would depend on supplies which are coming from abroad. And then also the suppliers, bear in mind that at times you are not able to meet the costs of your supplies. And then at the end of the day, you find that you are not a priority. And then also the poor remuneration, payment of doctors, and benefits for health workers, which led to a brain drain, where some individuals would prefer to actually train and work in other medical environments that do pay them better. These challenges presented as an opportunity of learning and to devise strategies through which things could get better, and things go better through collaborations with organizations that supported the development of further cardiac surgical services, more training and recruitment of staff to improve and sustain cardiovascular surgical services in the country, as to mitigate the challenge of limited human resource. Then the expansion of services to cover other regions of the country through outreach programs. For years, there were outreach programs of teams from the Heart Institute that would visit regional referral hospitals to try and identify work that can be done, see patients, and then do referrals, those who need to come to the capital. And it is through this that you now have the further development of some regional referral hospitals able to do some surgeries, like the case of Mbagga and Jinja Regional Referral Hospital. Then among those of noting that there was limited space, there was a solution of a planned hospital to acquire more space for inpatient services, surgical services, and critical care services, but more on that, to train and to use that opportunity and that new space to train more professionals that will feel the need of the disease burden that is ever increasing. And this comes in the local training programs to rapidly train and equip young professionals to champion cardiovascular surgical services in the country. Now, with all those challenges we have seen, and ways in which challenges were turned into opportunities, when you look at the work of the type of patients who were seen at the Institute, there was a 7-year review of a paper which was published by Dr. Namiyonga and Dr. Liku and other colleagues, which did a 7-year review of patients who were attended at the Heart Institute. you see the numbers of patients. I won't go through them, but you would see that in that period of time, you have patients in thousands. And the work which was being done in that period of time, 2007 to 2014, later on in further slides, you will see that there were challenges of actually providing services for the volumes of patients in an institute which was growing. And you feel that colleagues who were available at that time were overworked. And at times you find that you have so many patients and you have less that you can do for them. Still, the 7-year review, you would see some of the complex heart diseases, hypoplastic left heart syndrome, univentricular heart, pulmonary atresia, and tricuspid atresia, all of which are seen in this country to show that this type of patients are there and they would require the services. Now, what are the types of surgeries that were developed and are at this stage able to be given? When you group congenital heart disease into two large groups of cyanotic lesions and acyanotic lesions, you find that you can safely do an ASD with a PDA, a partial anomalous pulmonary venous return, VSDs, transition AV canal defects, aortic valvotomy, subaortic resections, repair of an AP window, and repair or total correction of a double outlet right ventricle, complete AV canal, total anomalous pulmonary venous return, and valve repairs. And on top of that, also surgical palliation for some of the conditions that cannot be operated at a go, or lack a number of items or technologies that can meet their surgeries at a go, and you end up having it as a staged repair. When you look at the cyanotic lesions, you find notably tetralogy of Fallot, double outlet right ventricle with tetralogy of Fallot physiology, pulmonary stenosis, pulmonary atresia, and then surgical palliations. I don't intend to go into the details of this type of surgeries, but only to illustrate the amount of work from the other slides which we have seen of the disease burden and the 7-year review that identified the type or the profile of patients who would be seen in the clinics of the Heart Institute. And then now this shows you the responses or the type of surgeries which are done for them. And then we find that we also have closed heart surgeries, and among these you have pericardectomy. Pericardectomy in other medical environments can arise due to other causes, but in our environment in particular, you find that it arises from patients who have had pulmonary tuberculosis that complicates with extra pulmonary affectations, thereby affecting the pericardium. Then PDA ligations, like the surgeries which are being done now at the regional referral hospitals, and coarctation of the aorta, and then a number of surgical palliations which are done on off pump or on as closed heart surgeries. Those are surgical palliations that I had mentioned earlier. Now, this type of surgical palliations can buy you time and also a bridge to the total correction. And sometimes you find that a patient is not fit to be operated at a go or in a one setting, and you find that the only option which you have is to do a palliation that will guarantee that the child will still be alive for their next stage of operation as you buy time. And then some of them in given settings can be destination management, and patients get to grow to reach a certain stage where other solutions can be given. Among them, there are the systemic pulmonary shunt, which are given for cases where you have hypoflow of blood to the pulmonary vasculature, like in cases of tetralogy of Fallot with severe hypoplastic pulmonary arteries, pulmonary atresia, TGA with pulmonary stenosis, and single ventricle physiologies that exist with pulmonary stenosis. Then the other one would be pulmonary artery banding, which are solutions or variations for cases with hyperflow, that is too much blood flowing to the pulmonary vasculature, like in cases of double outlet right ventricle with VSD physiology, complete AV canals, large VSDs, and other single ventricle pathologies with hyperflow of blood to the pulmonary vasculature. And then once these variations are done, because these two are variations that can safely be done at the Heart Institute, you find that you need a second stage of what would follow. And in some cases, there have been just like 3 cases of where a bidirectional gland, which is a first stage of a Fontan procedure, has been done at the Heart Institute. Now, any institution which can do a stage of a Fontan procedure is an institution that has gained a certain level of expertise, technology-wise, clinical-wise, and it is a level of development which identifies a center or a cardiovascular center as a capable center. Therefore, with these experiences, it's with which you find that now you have solutions for the patients, but then the patient or the disease burden is enormous, and you realize that you cannot offer solutions to the patients as you would want, and then you start to find strategies. And among those strategies is to champion regional centers to see that some of the closed heart surgeries that are safe and meeting bare minimum at some regional centers can safely be done there. Now, when you look at the growth pattern of congenital heart surgeries in Uganda, at the start of the program in 2007, you had closed heart surgeries which were less than 20. I mean, open heart surgeries which were less than 20, and closed heart surgeries around 40. But then there was a pattern of development and growth. By the time you reached the peak just before the COVID pandemic in 2019, you had reached an almost hitting 140 cardiac surgeries at the Uganda Heart Institute, and that's a mixture of open heart surgeries and closed heart surgeries, with open heart surgeries almost reaching 100. Now comes the global pandemic of COVID. It affects the programs, and this was globally, not only us, but then as usual, low-income countries suffer more because you are in an environment which is heavily depending on donor support, and at that time also the donor support wasn't so much. And then the other economic characteristics of our setting come into play, and you find that there is a decline in the services that you would want to offer to the population. At the end of the pandemic, you start to have some growth and to regain momentum, which was already established. Now, when you look at this, you see in the development and growth of congenital heart surgery in the country, at the beginning in 2007, you had more cases done with collaborations and then teams, local teams doing less. But when you jumped to 2019 at our peak, where we had reached our maximum growth before the pandemic, you have the local teams doing almost the majority of the cases compared to the few collaborations that we still have. And this reaches an almost 75 on the case spectrum of the various cases which were done. Now, this one here illustrates 2005, before the reviving the programs. You had almost all patients who would require open heart surgery in the country getting their surgeries abroad, those with sponsorships, those with well-wishers, as everyone here at least has seen a mother or a family in the press, on TV, on social media, requesting for support from well-wishers. So these are what was happening in 2005. Then 2007, you have now programs for open heart surgery coming up and growing. To reach 2019, almost 90% of the cases were being done in the country. Now, this shouldn't be confused that this is a 90% of all patients. This is a 90% of the spectrum of cases that can be done at the Heart Institute or in the country. But then you still have another spectrum or another percentage like 10 that you feel that you need to refer due to a number of reasons, due to lack of a number of technologies, which we hope as we grow and as the other solutions which are coming up, like an establishment of a new hospital that will be well equipped for training and to reduce on the disease burden, will also further reduce on this disparity. Now, among the cases which I presented some of the variations we are doing, and I made a comment that when a center or a cardiac center is able to do a variation like a first stage for Fontan, which is a bidirectional Glen, is that there is confidence in the center. There is growth of expertise, technology-wise, and clinical experience or surgical experience, that you know that this center is on a trajectory of growth and can do a number of things. Now, I present a case of a 13-year-old female who weighed 39 kilograms, height of 150 centimeters, with an HB of 12.1 grams per deciliter, hematocrit of 38.6, and oxygen saturations of 65%. A cardiac echo was done, which diagnosed the patient with tricuspid atresia type 1B, absent RA-RV connection, right atria, right ventricle connection, hypoplastic RV, that's poor development of the right ventricle, large PFO with a right to left shunt, and a moderate VSD with a left to right shunt. A cardiac catheterization was done, which reported a restrictive VSD, severe hypoplastic right ventricle with good pulmonary artery branches with increased pulmonary vascular resistance. These echo images, hope this image can play. These are echo images of, sorry, something's wrong with the images, but these are the echo images on the first slide where there is RA and LV. The RA is the left atrium and the LV left ventricle. Then you have the RA, the right atrium, which you see is well developed, the sizable chamber, and then the RV, the what would be the right ventricle, is a poorly developed chamber, which is further seen on the other slide. You have the left ventricle, you have the left atrium, the right atrium, and then you have the poorly developed or a hypoplastic right ventricle. And then you have the absent tricuspid valve, which is the diagnosis of the tricuspid atresia type 1B. Now, this is the patient who had a bidirectional Glen shunt and a pulmonary artery banding to control flow to the pulmonary vasculature through the MP main pulmonary artery, and you have a bidirectional flow through the Glen shunt. This patient, after surgery, stayed in ICU for 4 days. The total hospital length of stay were 8 days. There were 0 postoperative complications. The 30 days mortality was nil, and the patient is alive in follow-up. We had seen that their oxygen saturations were 65%, and after the Glen shunt, you have a 74% of oxygen saturation. The post-op cardiac echo reported normal cardiac function and normal flow of the Glen shunt. PA band was seen with severe band stenosis later on in follow-up. the point of sharing this experience is on sharing one of the highest cases that can be done. And as I mentioned, and I stress that there are some cases which are done, and you see that, and you note that the level of development of a center is adequate and is on a positive trajectory. And it is through this experience that now we are turning around and we say that now this can be done in the country, and we have reached this stage. But we're in a country of 48 million population with only one center, which is located at the Uganda Heart Institute in Kampala. Now, what happens to the patient who has got a heart disease in Moroto and cannot find transport from Moroto? A patient in Zombo, patient in Kisoro, or fine Bondobujo, what happens to them? And can all of them get service, or can all of them get to travel to the capital? The answer is no. So here are the solutions where you start to champion some of the services and growth at regional centers which can grow and start to cut out some of the services. And then they will also gradually go through the levels of development where the institute passed and reach a stage where you find that a number of cases can be done at Jinja safely, or a number of cases can be done in Mbagga, can be done in Kisoro, and you have good development of cardiovascular healthcare. And then some of the complex cases, those can be referred to the institute, or who knows, even in future development, some of these centers can establish themselves as centers of referral for complex or for unique repairs. Now, what are the future perspectives of the institute and the development and the experiences which have been acquired? The future perspectives, key is the new hospital for the Heart Institute with the desired space for all services. These services are inpatient services, critical care services, ICU, HDU, cardiac theaters, and catheterization labs. Now, what comes with these services give an opportunity for training, to know that all cardiovascular health specialists can be trained here, and trained, tailored for our regional needs, our national needs, and then even our regional neighbors. Then you have strategies to increase government funding, which is already happening as improved funding for the programs, and strategies to seek and improve on collaborations. Goodwill in cardiovascular healthcare is there, and especially for congenital, there are programs which support surgeries for children. And if one taps in those, they can be opportunities for growth, and for growth not only for the public, but for even public and private partnerships. And then robbing government for more cardiac centers at regional hospitals with a vision to improve cardiovascular service delivery nationwide. This slide shows our cardiovascular theater at the Uganda Heart Institute. When you notice, you see a number of equipments and you see a number of professionals. These are cadres who have trained and are offering services, but the services which they're offering, they meet the one thing, the disease burden. They are aware that these services, they are only reaching out to just a tip of the iceberg of what is cardiovascular disease burden in the country. This is the catheterization lab, where a number of other interventions that don't require surgery, they are like opening up the chest through closed heart surgeries or open heart surgeries, can be done in the catheterization lab to close some defects and do some repairs. This is our cardiac intensive care at the Uganda Heart Institute in Mulago, which was inaugurated last year, a state-of-art ICU, which improves on the capacity which we had. And with this, we hope in future it is replicated to regional centers where you have multiple of these, and all of them doing one same thing on combating on the reduction of the disease burden of cardiovascular disease. Now, I hope this slide opens. If it opens, it will show of what is cardiovascular surgery in Uganda.
My name is Michael Kecho. I'm a senior consultant pediatric cardiac surgeon and head of the pediatric cardiac surgery program at Uganda Heart Institute.
Dr. Muhoozi Rwakaryebe. I'm a consultant pediatric cardiac surgeon at the Uganda Heart Institute.
I'm Mura Pascaline, perfusionist, working at Uganda Heart Institute, Milan Hospital.
We have an 8-month-old baby girl who has a condition commonly called a hole in the heart, ventricular septal defect, which is a communication between the two big chambers of the heart, an unnatural communication that shouldn't have been there. So today we are going to take this child to the operating room, and the task at hand is to ensure that that hole is closed. This baby, because of this large hole, has been in heart failure. And the baby weighs only 4.5 kilos at the age of 8 months. By 8 months, she should be weighing about 9 kilos or more. This surgery is done by opening the sternum, and the sternum is the breastbone, and it is done with the help of the heart-lung machine.
Here is the heart-lung machine. The heart-lung machine is a blood pump, but it provides other functions like suction. Now, during open heart surgery, the surgeon needs a heart which is asystole. He needs a heart which is not beating. He needs an empty heart. And this heart should not even receive blood. So it is the heart-lung machine that takes over the functions of the heart and lungs during the time when the surgeon is repairing intracardiac defect. So here, blood is drained from the patient into our system, whereby it is filtered, it is pumped and oxygenated back to the patient. We also provide myocardial protection by arresting the heart, keeping it cold during the time when the surgeon is repairing the intracardiac defect. And when the surgeon has finished with the repair, the patient is rewarmed, the heart starts beating, and cardiopulmonary bypass is terminated.
So because of this, we have many people in the operating room, different specialties, from the surgeons who do the actual surgery, the anesthesiologist who handles the aspects of anesthesia, that is putting the patient to sleep, monitoring the patient, keeping them sedated, and so on, and administering drugs. The perfusionist who operates the heart-lung machine, operating room nurses, biomedical engineers. We are able to do open heart surgeries for about 85% of the conditions that children with heart problems present with.
Well, our patients, once they have been operated, when they leave theater, the operations, you find that will depend on which type of operation we have done or what was the condition of the patient. So these patients will be admitted under critical care services in the cardiac intensive care unit. Now, these patients will recover differently depending on the number of factors. Among them is the type of defects which have been corrected, which have been operated, and the other comorbidities, or let's say the other associated diseases that these patients have been presenting. In our environment here, most of our patients with heart defects are operated late compared to developed countries where resources are immense and available to do all surgeries, and you have various centers. So here you find that we have one single center, the Uganda Heart Institute, which is capable of doing these surgeries for a population of Uganda of 45 million population. So it will be difficult that all these patients coming out of the 45 million operated on time. To give you an idea of the statistics, you find that in the country, each year we have about 1.6 million children who are born, and with this, let's say 1% of them present one congenital heart defect, which might need surgery or any intervention or management. So the patients are many, which means that one single center cannot manage them as how they present. So some of these patients are operated late, which means that their cardiac function or heart function, together with their cardiorespiratory, respiratory lungs function, will have deteriorated. And once they are worked on, some will stay in ICU requiring life support or mechanical ventilation longer than habitually what would be necessary.
Having said so, we are not able to offer this service to everybody who comes because of limitations. Which limitations are mainly to do with funding of the surgeries. They tend to be quite costly, availability of materials, different supplies, lack of adequate numbers of healthcare professionals, and inadequacy of the facility in terms of the operating space and ICU and so on. So we hope that in the future, we're able to offer this service to many more patients than we have been doing at this stage.
I decided to add on that video as an explanation of some of the services. And one thing keeps on coming, the disease burden. The disease burden is immense. The patients are many. And these patients cannot all receive solutions in one single center, which is in the capital. Hence, the programs which we are developing through the leadership of the Institute with the support of our funders, that is principally government and the Ministry of Health, and then the need of awakening the population and the leadership to know that some of these things can be safely done at regional centers once they are supported and once there is a bare minimum. And then also remembering that there is the need of human resource development, which will come and cater for these services. And then champion this change that we all seek to see, that there are more services in line with cardiovascular health services in this country of ours. With that, I end the presentation. I think there will be a session for questions. Dr. Tenywa. Dr. Tenywa.
Yes, Dr. Muhoozi, thank you so much for the very excellent presentation. It has been very informative, and I think all of us here, we have learned something. Before, people thought that the Uganda Heart Institute was not doing too much cardiac surgeries, but now from what Dr. Muhoozi has presented, we can ably say that Heart Institute can do most of the operations. And as you saw from the graph, before in the 70s, 80s, most of the children were being referred abroad, and now most of the babies are being handled by Uganda Heart Institute. which is a very big plus. And as you also saw, heart surgeries have increased over time at Uganda Heart Institute, being done by the local team. And the other thing is the main objective is also to open up regional cardiac centers across all the regional referral hospitals. So we want to thank again Dr. Muhoozi for the excellent presentation. And I think all of us now, we know where Heart Institute lies right now, and we can send children there and even adults who need heart surgery. So thank you so much. Now is the time for Q&A. We are going to take maybe 5 questions at a time. But before people start asking, maybe I can ask if someone was asking, in case a nurse, a doctor wanted to join cardiac training at Uganda Heart Institute, what is the procedure, Dr. Muhoozi?
Dr. Tenywa, repeat the question, please.
Someone was interested in knowing if someone wants to go for cardiac nursing at UHI, wants to go for cardiac surgery at UHI or cardiology training, be it pediatric or adult cardiology, what is the procedure for joining the institution for training?
Okay, we can take more questions. I like a group of 5, and then I answer them at a go.
Okay, so you can just unmute, you just unmute and you ask. The floor is open.
Hello, good evening, doctors.
Good evening to you.
This is Dr. Matovo. I'm just asking about the period in which if the first patient or we've had surgery or been operated upon, how are they thriving? Like, how are they? Have they come back for review, and are they doing well, or the post-surgical complications? Just a clarification about those.
Thank you, Dr. Matovo. The next question, you just unmute and you speak. Any other question?
Hello. Dr. Kecho here.
Yes,
I posted a question on the chat requesting, first of all, thanking Dr. Muhoozi for the presentation, and also requesting him if he could tell us a little bit about the role of cardiac catheterization, the management of congenital cardiac lesions.
Thank you, Dr. Kecho, for that question. Maybe the two, we can take
Dr.
2 more.
Tenywa, I can be answering those as we get more questions.
Okay, you can go ahead, Dr. Muhoozi.
Thank you, Dr. Kecho, for the question, role of cardiac catheterization in the management of the cardiac patient. Now, cardiac catheterizations as auxiliary for diagnosis, they exist in one, to study defects or to study the cardiac patients. Once you have a diagnosis and you need more information for planning surgery, the timing of surgery or operability of the patients, a diagnostic catheterization can be done. And this diagnostic catheterization will be done in the cath lab by a team of intervention cardiologists. And then there can also be therapeutic, in which in the cardiac catheterizations, there are treatment and management strategies which can be achieved for the heart patient. Among them is crossing defects. Defects like PDAs can be coiled in the cath labs, passing through the vein, can reach the heart, or in the arteries, can reach in the heart and implant a coil which occludes a defect. This can be done still also for ASDs, atrial septal defects, which are normally operated via open heart surgery, but if they are adequately sized and without existing alone as single defects and meeting the criteria for occlusion, they can be worked on in the catheter by implanting an occluder, which also passes through the vesicular access or through a blood vessel to reach the heart and close them. Now, those are the two principal roles of cardiac catheterizations. One, for diagnosis, studying the defects further to offer more insights on the management. This management would be more of medical management or a planned surgical management where you get more information to plan adequately for your surgery. And then the other one is the therapeutic part where you use the catheter as a strategy for managing or closing defects. Those are the two principal roles of cardiac catheterizations. Now, a question on training. The number of training programs at the Uganda Heart Institute. There is a training program for a fellowship in cardiac nursing. There is a training program for a fellowship of critical care and anesthesia. There is a fellowship for cardiac surgery. There is a fellowship for critical care nursing and a fellowship for pediatric cardiology. There is a fellowship for adult cardiology. All those are training avenues, and the criterias are different depending on the line of entry of the different cadres. The fellowship for surgery receives surgeons who have finished their masters in general surgery and have an interest of further training in cardiovascular surgery. They can apply once they meet the criteria for the fellowship. Now, the fellowship for cardiology also receives fellows meeting that criteria. So as the fellowship for cardiac nursing, an individual who is interested in these programs can always get information from the Heart Institute, the website. In this forum or this, it would be more broad if I told you all the criteria for joining the programs. The information is that there are training programs, and these training programs take in candidates who have been selected who meet the criteria to join the training programs. A question regarding patient review. Thank you, Dr. Matovu, for that. All of the patients who are operated are reviewed and are followed up. These follow-ups are short-term and long-term, and then others are designed when there is cases of interest, like a case which was operated and you know that at a later stage you have got to follow them up with another surgical strategy, especially in palliated cases. Yes, we do follow up our patients, and it is through this which actually you also evaluate your work, your quality of work, and to know the survival rates of your patients. Dr. Tenywa, any other questions?
Hello.
Yes, please.
Thank you, Doctor, for this wonderful presentation. Dr. Muhoozi has highlighted the surgeries, especially in the regional centers like Jinja and also one from Barara. I would like him to maybe give a comment on the referral system, especially regards the peripheral centers in those respective regions, or we can always still consider the national center. Thank you.
Thank you. And Dr. Muhoozi, in the chat, Ezra is asking, a friend shared an echo report of his 3-month baby, which showed Ebstein's anomaly of the tricuspid valve with severe low pressure tricuspid regurgitation. So he's asking, can he be helped at Uganda Heart Institute? Then the second one is asking that is there a time limit, like for a particular age, to offer the therapeutic surgeries? Maybe you can answer those two.
Thank you very much, Dr. Tenywa. David, referral system. Notably, there are two regions or regional referral hospitals where there is a resident pediatric cardiologist. In Uganda, that is Mbagga Regional Referral Hospital and Jinja Regional Referral Hospital. And those cardiologists who are stationed here, like the one here in Jinja, Dr. Tenywa, they do capture patients who come at the Regional Referral Hospital. But let's say a physician or a doctor, a pediatrician is in Uganda and has a patient, you have a choice. You can always refer the patient to Jinja, and then they get the first management or the first strategy. And once they realize that there is need to refer to a higher center, they can refer to Heart Institute. But then for others in other regions, they can always refer the patients with the usual referral system to the Uganda Heart Institute. Now, this is one of the challenges which we have always known and recognized, that at times it would be hard to refer a critically ill patient with cardiovascular disease, knowing that some of our patients reach the referral systems or reach the hospitals when it is late. And we pray that in the future, where you have these regional centers well equipped and planned for, you will find that a patient who is in the farther east, you can easily refer your patient to Mbare or Soroti, and you'll find there is a cardiologist who will manage the patient. And then if it is something that cannot be handled at the region, or something which would now require surgical management that is not available in the specific region, then the patient is referred to the higher center, that being the Heart Institute. But today in time, yes, we can still refer patients to the Uganda Heart Institute in the normal referral systems at from regional centers or peripheral hospitals. A question on the timing for surgery. One, we have to note that in our environment, patients do reach when it is late, and we can't use the timing of surgery, the one which is described in the book, where you find that certain defects are better operated at this time. Here we operate patients at the time when they reach us. Now, there are known aspects, scientific aspects of which you know that the later surgical strategies offered, recovery might be cumbersome, like patients whom you find that have developed, who have defects which present with left-right shunts and have developed pulmonary hypertension, rendering them inoperable, but can still get medical management. But then patients who have been on treatment and followed up, they can also be operated at a late stage. So it all depends on the characteristics of the patient and the defect and the disease which they are presenting, and all those factors come into play to translate into the adequate timing of surgery, in which now would term as, is the patient operable or not? If it's not operable, now what are the other palliative strategies that are available for them? And that's where cardiac medical palliation comes in, to palliatively manage the patient that has been rendered inoperable. But for most of our patients and the numbers which are there, we operate them as they present to us, and then we prepare them to see if they are adequate or not adequate to be prepared, to be operated. A question online, which is regarding a child with Epstein, Epstein. Thank you. Let me look through the question one more time. Usually, I would prefer that in cases where somebody has more of a clinical query, the question goes, a friend shared an echo report of his 3-month baby, which showed Epstein anomaly of the tricuspid valve with severe low pressure tricuspid regurgitation. Can he be? I would advise that this patient gets referred to the Uganda Heart Institute. We assess and evaluate the patient. it goes as a message that whenever you have these scientific interactions like in presentations and then there is a clinical, I wouldn't concretely give you information regarding how the patient will be helped or if the patient can be operated, because that echo I'm not seeing it and I don't know what it is stating or the other. But bottom line, let this child be referred to the Heart Institute. We shall gladly review them at our pediatric cardiology clinics, and then we plan for them or we advise accordingly.
Thank you so much, Dr. Muhoozi. I think we just go for the last comment. Someone in the chat is asking, I understand that Uganda Heart Institute operates at some costs. How are the costs arranged to cater for the majority of Ugandans in terms of affordability?
Thank you very much, Dr. Tenywa and Ronald, for that question, Ronald Alema. Uganda Heart Institute is a government institution which receives funding for its programs. But then heart surgery or cardiovascular health sciences are not a cheap or an easy venture. Number one, all things which are used, for instance, for open heart surgeries, things which are not produced in our common market nationally, are not produced in the country, and they are not produced in our common market, that's being East Africa or COMESA. These things are imported from abroad and at a cost. And then when you look at the global cost of heart surgery, to put it into perspective, we have all seen mothers or parents who are requesting support in the papers on social media to take their child abroad for surgery. They're always looking for to the tune of above 60 million Uganda shillings. But here, you find that the cost of heart surgery is a small fraction of that 60, 80 million. Message being that the programs of the Heart Institute are supported by government and the services are heavily subsidized, in that the other part which is expected from the patient is not as massive as compared to when there is need to have surgery abroad. And then also for affordability, there are other strategies which are evaluated on a case-per-case basis. And again, to reiterate that the programs are supported by government in a public institution. So the other aspect of a cost sharing on treatment would be as a small fraction or an expected fraction from the patient as their contribution, not a wholesome pay for the service. If it would be a wholesome pay, you would find that it is to the tune of, let's say, 30 to 40 million, which is not the case. It is a small fraction of that.
Wow, what a brilliant answer! Thank you so much, Dr. Muhoozi, for the very brilliant answers. I think it is 9 minutes past 7. I want to just invite Dr. Peter Lwabi, who is the Deputy Executive Director, to give us concluding remarks about today's presentation. You are most welcome, Dr. Peter Lwabi.
Thank you, Dr. Tenywa. And I would like to thank, first of all, the presenter, Dr. Muhoozi, for that excellent presentation. I'd also want to thank all the participants for attending this interesting discussion. Mine is discussing the take-home messages. One, we have seen the natural evolution of Hello? Can you hear me?
Yes, we can hear you, Dr.
Hello?
Lwabi. We can hear you.
Sorry, some interference, yes. So I'm saying the lessons we are drawing from today's presentation is that there's certainly a burden of cardiac disease Two, it is clearly demonstrated that the capacity to develop these centers of excellence is possible. And three, there's a need to scale up these services in order to address the big challenge we face as a country. The visit on the camp to Jinja has clearly demonstrated that the capacity and the goodwill is available. Our question and our challenges are we in position to stimulate this further growth? This further growth will call for investment in key areas of infrastructure, developing the necessary human resource, and then finding mechanisms for sustainability. These are the questions we should be discussing. One more area we need to look at, and this does not only address congenital heart disease, it also looks at other conditions, is the promotion and prevention of some of these conditions. Much as we know that the majority of the congenital diseases have a genetic preponderance, we know there are a few simple interventions we can use. For example, a lot of PDA conditions may be associated with congenital rubella, for which a vaccine is available. And we know the other issues of drugs, alcohol abuse are all things we can look at and mitigate. The question that has also come up, which is very important, is the training. I'm glad that these questions came up, and we are advocating and pushing for a structure that recognizes the various disciplines that are involved in cardiac care. Dr. Muhoozi may not have mentioned other areas like cath lab technologists and technicians, perfusionists, people who work in the cath lab that monitor the radiation. But all these are areas that have potential for training. And once our human resource structure and job descriptions are complete, this is information that will be shared across so that people can choose a career path that may not be specifically to be a surgeon or a cardiologist, but to be one of those other important people who support the whole system of cardiac care. So these are areas that are potentially available, and would encourage people to look at them as a way of looking at career progression. Sustainability is a very important issue, and that is a discussion that is ongoing. As we wait for the health insurance to come online, what are the other strategies we can look at that look at financing and resourcing these other areas? We also know that Dr. Muhoozi mentioned that the majority of our items are imported. What is it that we can start looking at in terms of research and development that we can actually develop here and definitely bring down on the costs? So I think this has just been a good opportunity to stimulate discussion, and I would encourage further discussion in these areas. And a big thank you to the whole team, and thank you for the successful mission at Jinja Hospital. And we wish everybody well and have a good evening. Thank you.
Wow, thank you so much, Dr.
Thank you very
Rwabi,
much, Dr. Rwabi.
the Deputy Executive Director of Uganda
Welcome.
Health Institute. We are really honored. Thank you for the words of wisdom. And Dr. Wilberforce Taweru, on behalf of BHF, we can give maybe a vote of thanks, and we go.
Thank you very much. Let me take this opportunity to thank my teachers, my colleagues from Uganda Heart Institute for sparing their precious time to come and do the following things in Mbagga. One, service delivery in terms of cardiac surgeries. This has made history in Uganda and in Mbagga at first, and then secondly, training. I know if we actually Mbagga gets a center where some of the surgeries can be done, it will go a long way on reducing the number of patients that we have in that region. And also it can also be earmarked for training as a center of excellence for training other people in the near future. And obviously the other thing that has already alluded to by Dr. Rwakaryebe, that actually research is very important. So we want to thank Heart Institute, the government of Uganda, Jinja Regional Referral Hospital, our colleagues for spearheading this. And we want to say that let this not be the end, but let it be a continuous process, so that at the end of the day, we actually deliver wananchi who are safe and able to push Uganda to another level. So with these few words, I want to thank Dr. Muhoozi and his team and all the Mbagga at large for hosting and then staying with these rare, I could call them rare species of specialists in this country. And we say that thank you very much. There is nothing we can say apart from that, and we say that let this not be the end. The Mbagga say chongero, that you give us more and more and more. And we want to wish you the best as you stay in Mbagga and serve the people, but make it a routine, and then you come and put a Jinja regional referral to service so that they can also look at patients. So with those few words, we want to thank you very much, and may God bless you all for God and my country. And on behalf of Mbagga Health Forum, actually, we are going to say, please come again and come again and come again. May God bless you all. A good evening.
Thank you so much, Dr. Kabweru. Without any other ado, let me thank every person who has logged in. Thank you so much. We are humbled. Thank you for sparing time. And I wish you a good evening and a good night. Bye.
Goodbye. Thank you.